Good afternoon, ladies and gentlemen, and welcome to today's webinar. I would like to remind you that this conference is being recorded. At this time, all participants are in a listen-only mode. For those connected by telephone requiring operator assistance during the call, please press *0. Web participants requiring support should use the chat feature on your screen. I would now like to turn the meeting over to Mr. Stephen Samus, Vice President Programs at CFHI. Please go ahead, Mr. Samus.
Thank you very much. Hello everyone and welcome to today's On Call informational webinar, Accelerating Health System Transformation in Saskatchewan, Lessons Learned from the Saskatchewan Surgical Initiative, and it's brought to you by the Canadian Foundation for Healthcare Improvement. CFHI is a pan-Canadian organization funded by the Government of Canada, and we're dedicated to collaborating with health system leaders across the country to accelerate healthcare improvement for Canadians. While I introduce today's session and our guest presenters, please take a moment to introduce yourselves and your organization using the chat feature on the right of your screen, if you've not done so already. We are always delighted to see the names of the various people from around the country and outside the country from time to time who are participating in the webinars. As you heard, my name is Stephen Samus. I'm Vice President Programs here at CFHI, and I'm really pleased to be the host of today's webinar. Joining us today on the webinar are Dr. Gregory Marchildon, who's Professor and Canada Research Chair in Public Policy and Economic History at the Johnson-Shoyama Graduate School of Public Policy at the University of Regina in Saskatchewan. And also with us is Sharon Bishop. Sharon is currently a PhD candidate at the Johnson-Shoyama Graduate School of Public Policy at the University of Regina and under the supervision of Dr. Marchildon. I'm also really pleased to say that we have more than 70 organizations registered for today's session, representing people from regional health authorities, universities, hospitals, and health centers. It's a pleasure to have all of you on the line for today's call. Today's webinar really stems from a partnership that was created between the Ministry of Health in Saskatchewan and CFHI about 3 years ago, which was really to try to understand healthcare transformation in a large system like in Saskatchewan by really trying to understand how transformation in healthcare occurs, the barriers and the facilitators to healthcare transformation, and really try to understand how healthcare transformation happens in real time. It was also conceived as a partnership that would enable the transformation project in Saskatchewan to be able to have a feedback loop in real time by creating an opportunity for someone to be not only tracking the story of the transformation journey that was underway, but to be able to intervene and provide that feedback loop when, as the projects were underway, as the program was underway, to be able to in real time facilitate course correction if necessary. So what we did was we decided to attach an individual to two transformation initiatives underway in Saskatchewan, and today we're going to talk about the Saskatchewan Surgical Initiative. And so Sharon was brought on to be that person who was going to track the transformation journey for the Saskatchewan Surgical Initiative and really help us uncover the lessons learned for that initiative as it was underway and create that feedback loop inside the Ministry of Health so that she was able to help them to course correct as they went through the process. Under the direction of Dr. Gregory Marchildon at the University of Regina, she's also working on her PhD on transformation in healthcare. So it was kind of a combination of an opportunity for Sharon to study the process of transformation as part of her PhD, but then to also prepare a report for the rest of us and a knowledge for the rest of us around healthcare transformation and how it occurs and what its barriers and facilitators are. So we're really pleased today, 3 years or so after we initially started that process, to welcome Sharon and Greg today to offer their lessons learned and really try to help us get to the learning objectives for today's session, which is to explore the change processes, to better understand and identify the factors that facilitate or inhibit large system transformation using this unique real-time collaborative approach, to learn about the critical factors that contribute toward and impede large large health system transformation, like the Saskatchewan Surgical Initiative, and to better understand how to address and overcome the barriers to large system transformation, and then also to use that knowledge so that in future we can accelerate the changes that are underway. So today's session will begin with brief presentations by both speakers, and then we'll open the floor to you for an interactive question and answer period. Further instructions will be provided by me later on about how we will do the chat feature, but feel free to keep the conversation going in the chat box throughout the presentations, and we'll be watching for those over time. It's now my pleasure to hand the floor over to Dr. Marshallton and to Sharon. Please go ahead, Dr. Marshallton.
Thank you very much, Stephen. And as Stephen Samus has already indicated, this is really a unique three-way partnership, really the first time that something like this had been created in Canada. It started as a conversation between the Canadian Foundation for Healthcare Improvement and the Deputy Minister of Health in Saskatchewan. Eventually, it turned to me when the Ministry of Health asked how this could be constructed with a PhD student. In that conversation, we discussed the potential benefits to the ministry, to the student, and to the Canadian Foundation for Healthcare Improvement. And I should state that while we could identify the benefits with some degree of accuracy at the beginning, we only had the vaguest idea of some of the challenges that faced us in this arrangement, and I thought I'd just spend a couple of minutes reviewing those challenges that we solved over time. The first was the division of intellectual property, and this was very important, but over the first year of the arrangement, we came to what we felt was a clear demarcation between what was the Ministry's intellectual property and what was Sharon's intellectual property in terms of her thesis, so that any work that was really initiated and generated by the Saskatchewan Ministry of Health remained the property of the Saskatchewan Ministry of Health, and Sharon had the right to use that material in her thesis, but it was listed as Saskatchewan Ministry of Health, even if she was directly involved in the creation of that material, either in terms of the interview process or in terms of writing up a report. That report was a Saskatchewan Ministry of Health report. In terms of her own interviewing, which she did at her own initiative, and she defined herself, she went through the usual ethics review process at the university, and she made it very clear as part of obtaining consent from her interviewees that this was being done in her own capacity and not at the request of the Saskatchewan Ministry of Health. And I think that this demarcation has stood the test of time. Building of trust, of course, that took time. That was very much a process that was specific to the unit that Sharon worked in and the people that she worked with, and her ability over time and the receptiveness to her role over time within the ministry. It is always difficult in a situation in any organization when you have somebody who is not salaried directly by the organization and questions about where loyalties lie. But I think that over time that Sharon was able to convince and most people at any rate that her interests, although they were divided between her thesis and the work that she was doing for the ministry, were ultimately quite compatible. In terms of managing risks, this is best dealt with by discussions in advance where there's some clarity laid out in terms of the research, presentation, and publication, and some opportunity for the ministry to review any material that will be disseminated either in presentation format or in publication format in advance. In terms of the actual work done within the ministry, of course there is an emphasis from the ministry's perspective on evaluation, whereas Sharon's work was more broadly defined in terms of her conceptual research as part of a thesis. And again, the only sort of way to deal with that was for there to be discussion about the similarities and the differences between those two. Of course, there are also larger policy implications that go well beyond the case study in terms of the surgical initiative here, and those are going to be the subject of Sharon's thesis. And some of those may go even beyond the work that has been provided to the Canadian Foundation for Healthcare Improvement and that report. But what you see are really three different levels. One is the Saskatchewan Ministry of Health and what their expectations were in terms of work, the Canadian Foundation for Healthcare Improvement and its larger transformation model, and then Sharon's own work, which deals with the scholarly literature in a more conceptual way. Thank you.
Okay, so thanks, Greg. So in brief, as a result of the partnership described previously by Stephen and Greg, I've had the unique opportunity of being embedded as a researcher within the Saskatchewan Ministry of Health, within the Saskatchewan Surgical Initiative. Throughout this presentation, I'll refer to it as the SkSI. So the SkSI is a provincial large health system change effort pursued by the Ministry of Health in an effort to reduce the wait times for elective surgery to no greater than 3 months. So firstly, I'd like to thank you all for the opportunity, and I appreciate your participation in this on-call webinar today. I'll provide a brief overview of the research findings and approach taken, followed by a succinct, pithy summary of findings. And in conclusion, I'd like to highlight the relevant policy implications and lessons for clinicians and decision makers such as yourselves who are potentially embarking on or are in the midst of large-scale system-wide change initiatives. Today I'll be presenting high-level findings, and for those of you with an interest in the specific details or more of the how the surgical initiative was undertaken, the complete report is included as a reference material for this webinar, and it can also be found in the report section at the CFHI website. So this research project lasted 29 months and was conducted from September 2011 until January of this year. I can attest that this cartoon accurately describes how I felt many days along this journey. As Stephen mentioned, I'm currently doing a PhD at the Johnson-Shoyama Graduate School of Public Policy as well. So to kick off, I'll briefly go over the question that guided this research and the preparation of the final report. So I intended to explore and identify the critical factors that contribute toward and impede large-scale health system change using the Saskatchewan Surgical Initiative as the case study. For this longitudinal research, I adopted a mixed method approach. As with any major provincial system-level initiative, many organizations and stakeholders play a critical role in implementation and influencing the eventual outcomes. The use of the multiple data sources and varied data collection methods permitted me a greater breadth of coverage. In the regard to the participant observation, I was limited to a fairly restricted range of people, incidents and localities. I couldn't be everywhere I wanted to be all of the time. So conducting the interviews enabled access to a wider variety of people and situations. So for the interviews, I conducted 2 rounds, the first in April 2012 and the final more focused round late last year. I was very pleased with the high response rate of 75%, which in my mind speaks to the interest in this type of research and the engagement of many throughout our system. All told, in the final round, I conducted 46 semi-structured interviews over September and October last year. I sought perspectives from far and wide across the province and fortunately was able to speak with many folks from all levels within the system, both internally and externally. Similarly, adopting a multi-method approach facilitated the in-depth exploration of a wide range of issues that were simply not amenable to observation. So things such as leadership, personal experience, roles and responsibilities, as well as personal perspectives on change. So while my data sources were field notes and interview transcripts primarily, I also used public and privileged documents as secondary sources. Okay, so let's move on to the interesting part. What did we learn? So from this research, I draw 5 core findings, or factors, that have facilitated large health system change using the SkSI case study example. They're presented in no particular order of importance. But at this point, it's important to note that there is apparent synergy and interdependency between the concepts. Essentially, energy has to be invested in all 5 areas at the same time to see the desired outcomes achieved. I presented the findings in the positive as facilitators, though generally if the factor is absent or there is room for a substantive improvement in a particular area, the opposite would be true, and the factor would then be considered a barrier to advancing transformation. So let's run through the 5 core findings in brief, and I'll discuss each one in more depth as we move along. So starting at 12 o'clock in red, moving clockwise, the factors that I identified as key to facilitating large system change were the following. So 1, using performance measurement more comprehensively. 2, fostering a culture of continuous improvement, and in this case using lean. 3, adopting patient and family-centered care. And 4, improving designated or more formal leadership. And 5, enhancing distributed leadership through networks. So moving on to each factor in more depth, it is clear that effectively addressing elective surgical wait times requires a common vision and a comprehensive policy framework, which needs to be inclusive of the entire surgical continuum. It was and continues to be important to consider the surgical journey from a patient's perspective, and this essentially requires system-level measurement and reporting of elective surgical wait times at both the wait 1 and the wait 2 time periods. For several of the SkSI sub-initiatives, specifically those related to safety and quality of care, progress was hampered by the lack of high-quality intelligence available at the individual and the organizational as well as the system levels to drive improvement efforts. I'm sure many of you are watching with close interest the province-wide lean experiment currently underway. While it wasn't a central focus of this research to examine lean, it was pretty hard to ignore. So from a qualitative perspective, the rigorous application of lean methodology has established standardized routines and processes within the province, which have essentially enhanced accountability among stakeholders and supported daily use of measurement to drive improvement efforts. Moving on to the second factor, continuous improvement. Applying one improvement method, lean as I mentioned, province-wide, has significantly modified organizational arrangements and added discipline and rigor to continuous improvement processes. It's introduced a common lexicon, which has allowed for better communication within and between organizations. Through the application of lean, and when I mention lean, here I most specifically refer to Hoshinkanri, or management by policy, and the use of daily visual management, an environment has been created that better aligns frontline activity with organization and system-level strategic direction. It fosters a culture of continuous improvement and enables forums which allow for team engagement, knowledge sharing, and mutual learning. Another key point to note within our system is the autonomy physicians assume. This generally enables them to voluntarily opt in or opt out of participating in government-led initiatives such as the SkSI, or lean for that matter. Essentially, governments rely heavily on the cooperation of the willing. So within the constraints of the current context, targeted policies are necessary to support physician participation. It was clear that the patient and family advisors, administrators and clinicians alike value meaningful engagement and partnering with patients and families. Fundamentally, by involving patient and family advisors in strategic initiatives and clinical process improvement activities, the group dynamic is altered. It facilitates downward accountability to health service users, and as one key informant stated, it truly does change the conversations. So health system stakeholders must be willing and open to hosting diverse ideas and learning and adapting as a result of patient and family involvement and input. The fourth key factor is designated or more formal leadership. As we are all acutely aware, effective leadership is an important enabler of organizational and system-level performance. This research revealed that there was considerable variation in the quality and effectiveness of leadership demonstrated by stakeholders central to the SkSI. It is evident that developing both administrative and clinical leadership capacity is paramount. Despite unprecedented levels of frontline engagement within the SkSI, it continued to be perceived by stakeholders at all levels to be a top-down change initiative. A missed opportunity was to include more frontline providers, particularly physicians, to empower and directly engage them in shared ownership and responsibility for achieving the initiative goals and objectives. To compound this further, throughout the system there is an overwhelming perception of change fatigue. Essentially, the system is running too hot. So to better appreciate this slide, I'll briefly provide you with some context. For the SkSI, an executive sponsorship group and a larger guiding coalition was established to steer the province-wide initiative. This was an innovative change management approach which included approximately 100 individuals representing diverse stakeholder interests. It ended up being a very effective tool to garner support for the reform effort. Consensus exists amongst health system partners that through the necessity to work together to achieve the common goals of the SkSI, relationships have been strengthened. A culture that values collaboration, teamwork and learning is being fostered. It is also important to recognise that the SkSI wasn't occurring in isolation and that it was occurring within a much broader context, with efforts to improve alignment and strengthen the provincial leadership team and overall to think and act as one. It is imperative that leaders from across the system, from the executive levels to the front line, be engaged in processes of collaboration, teamwork and collective decision-making in order for change to be successful. So within this case, within a predominantly hierarchical structure where regions are accountable to the Minister of Health, the use of a strategic network has been a useful mechanism to balance the tensions that exist between the ministerial accountability and the need to engage leaders at all levels, or in other words, distribute leadership in order to achieve large system change. So in conclusion, I'd like to highlight the relevant policy implications and lessons for decision makers such as yourselves embarking on or in midst of the large-scale change initiative. Some of the initial lessons are more general in nature and some more specific. So seemingly the only constant currently within our system appears to be change, and considering that change fatigue is pervasive, it is important that decision makers be judicious when embarking on multiple major change initiatives in parallel, remembering that there are finite resources and attention to be allocated with the inevitable associated knock-on effects when you do. So as I'm sure you can appreciate, money greases the wheels, and having adequate resourcing certainly makes life easier, especially when focused and specifically on managing and supporting the change effort, as was the case with the Saskatchewan Surgical Initiative. So moving on to the more specific, comprehensive and balanced use performance measurement, which gives equal priority to sooner, safer, smarter elements, is imperative. So we need to adopt a more balanced approach when pursuing large system change. Establishing a system-wide vision, clear goals, and imposing strategically staged targets were beneficial in this regard. So again, both top-down and bottom-up approaches to change are required, as we all know, and as I mentioned previously, leaders from within the system at all levels need to be engaged in processes of collaboration, teamwork, and collective decision-making to achieve large system change. Frontline providers, particularly physicians, we all need to seek opportunities to develop personal and strategic leadership capabilities, to develop self-awareness and recognize experiential learning opportunities. And again, within the current contextual constraints, the use of a strategic network... Oops, sorry, I forgot to move the slide. So again, within the current contextual constraints, the use of a strategic network is a useful mechanism to balance the tensions between the ministerial accountability and the need to engage leaders at all levels. So thank you very much. I'll now hand the floor back to Greg to further elaborate on the larger process and policy implications.
So what are the lessons that we can draw from this 3-year experiment? And actually Sharon Bishop was one of 2 embedded research experiments that we had. Over the next 8 months, Stephen Samus and I will be writing up our conclusions from this particular project. We'll be providing a guide, if you like, for those that want to engage embedded researchers from the academic world into their respective organizations. We think that there are a fair number of future opportunities for health organizations and managers using this as a tool to better understand the nature of transformation within their own organizations and to tailor their transformation efforts. I would invite you to draw your own conclusions on the quality and usefulness of this approach based upon Sharon's report for the Canadian Foundation for Healthcare Improvement. I would also state that there is a kind of a progression in terms of the implications of this type of work. First, and at the base is the exact case study. In this case, it was reducing wait times for elective surgery and what can be learned from that particular case and applying that to similar cases across the country. But moving up a level, I think that this study tells you a great deal about change management in general and can be applied well beyond the issue of surgical wait times. And then moving up yet another level to policy change, this kind of study indicates the areas where it may be useful to actually alter the environment itself, including financing system, incentives, organizational structures, to better pursue change. And then finally, health system transformation across the continuum of care. And this involves, of course, the knock-on effects from one area to another area, as well as the kind of thinking and planning that goes on within health ministries and occasionally regional health authorities in terms of more profound health system transformation. We want to thank you for your participation today, and we look forward to the questions and discussion.
Well, thank you both, Greg and Sharon, for your presentations and for the comments that are coming in, and we'll open that up in a minute. Just before we go to the questions that we might have and some of the comments on the screen, I would really just like to personally, on behalf of the Foundation, acknowledge the Ministry of Health in Saskatchewan for actually being a willing participant in this exercise. It's a pretty bold and gutsy move for a health ministry going through a major transformation initiative to say, yes, we will open ourselves up and be observed and be and have somebody there in real time to kind of track our progress, track the lessons learned, track the challenges as well as the things that are going well. And I think the Ministry of Health in Saskatchewan deserves significant kudos for doing that, because it is only through a process of real-time learning do we actually really shed light on some of the issues and factors that go into health system transformation, and from that we really have the opportunity to learn and do better. So I think a big thank you to the Ministry in Saskatchewan for this. Also to really acknowledge the excellent work that Sharon did, and particularly the relationships and the trust that she was able to build in the ministry in particular and with other stakeholders across the province. It can be a little unnerving as people are sitting in their meetings and planning their work, and especially a major initiative like this at a provincial level, and have someone who is not, have someone external sitting in the room taking notes, observing the process. And it takes a special kind of individual to be able to do that and work with the system the way that Sharon did, and I think that really needs to be acknowledged. And then final acknowledgement really to the very important role that Dr. Marshallton has played in steering the research, helping us at the very outset to understand all of the issues related to intellectual property, because it as Greg said, it was a bit messy at the beginning, and it was his expertise that really helped us to be able to understand who was really interested in what, and that was invaluable, as well as acting as an important liaison between Sharon, the Ministry of Health, and CFHI. So those acknowledgements I would just like to get out there at the beginning. I think they're very important. We look forward to continuing to learn from the work that Sharon has done. So we'll invite you now, open the floor to questions and answers. We invite you to put those in on the screen, and I'll attempt to facilitate them here as a few coming in. We do have a comment here, and I'll put this one to you, Sharon. It's from Diana Nolan, and it says, hope you expand on sooner, safer, smarter elements. And so that's probably wondering the extent to which the report expands on that, and we know that that's part of the Saskatchewan government and the Saskatchewan Ministry's strategic direction around healthcare. If you could comment on that.
Certainly. So thank you very much, Diana Nolan, for your question. So I didn't go into that obviously because it's quite extensive, but generally the Saskatchewan Surgical Initiative went broader than just trying to reduce wait times, and that was a very strategic approach based on stakeholder influence and involvement. But they made it quite clear that it went across the surgical spectrum of care, and that it was looking at the sooner, safer, smarter elements. So looking at the sooner, obviously, is reducing the wait times, and the safer being like improving safety and surgical care for all patients, as well as the smarter elements of reducing variation and improving efficiencies and trying to get more surgery done, safe surgeries done in a more efficient and effective manner that ends up improving the whole patient's surgical experience. So I hope that answers your question. It does. It is covered quite extensively what the Saskatchewan Surgical Initiative policy framework looks like in the report. So if you're interested in further detail, by all means, please read that.
Great, thanks, Sharon. From Deborah in the Saskatchewan Ministry of Health, great presentation. Thank you. Can you expand or comment further, Sharon, on the targeted policies necessary for physician participation?
So thank you, Deb. Deb is actually one of my work colleagues, so thanks for your kudos there. As you're well aware, actually getting physician involvement has been quite challenging. So when I speak of the targeted policies, I mean things that the SMA, in collaboration with the Ministry of Health, some of their quality improvement funding initiatives, and also supporting physicians in participation through providing incentives and funding opportunities so that they're able to dedicate their time for quality improvement, and try to incent that involvement in the quality improvement facets of our work, and giving them the opportunity to free up their time so that they can focus on that sort of work. But I found that without that, I really think that that is definitely a considerable barrier, the fee-for-service model of care, a model of funding that we use. So.
Great. We have a comment from Darlene and then a question, so I'll read the comment first. I agree with the need for collective decision-making to support transformation and change. This is basically a how do we fix this together, excuse me, versus let me tell you how to fix this. So a commendation there. And then the question regarding outcomes specific to improving patient outcomes. Did the initiative include reviewing and supporting the appropriate referrals for the appropriate procedure so that the outcome would be doing more of the right procedures for the right reason?
If you do recall, I mentioned that having high-quality intelligence was actually a considerable challenge, so outcome data looking at specific surgical intervention. It's definitely the direction that the Saskatchewan Ministry of Health and the stakeholders want to move towards. So there are some initiatives that have taken a little bit time and taken a little bit longer to get off the ground, but they're definitely looking at variation in surgical procedures across the province and being a little bit more focused in that area this year. Again, I'm not certain where that progress has gone, but they're definitely looking at opportunities of using synoptic reporting to try, in certain areas in particular, to try and look at the outcomes and determine whether the surgery is actually the most effective means to achieve those outcomes. So. Thank you for your question.
Thank you. We have a couple of questions here that I'll read from Stephen, who is at Health Quality Ontario. And just a little aside to say that Stephen used to work here at CFHI before he moved to Toronto and on to HQO, and played an important role in this project at a certain course in its time. So it's great to have Stephen on the call. His first question is to you, Sharon. Looking back on this experience, first of all, what was the most important lesson you learned? And secondly, what would you do differently if you were to start again from the beginning?
Well, thank you, Stephen, for your question. Hello in Ontario. So looking back on the experience, and Stephen was very much involved in a lot of the beginning stages of it, I would say that the most important lesson that I learned was the importance of building those relationships and building that trust. And realizing that that does take a lot of time, and with that effort, upfront sort of effort, it really opens up and broadens the opportunities for someone in my position as an embedded researcher. I also think that it's important to not allow that to hold you back. at the beginning I often felt that I was looking for direction and trying to be cognizant of the people that I worked with and what they were doing, but to a point that I felt that I wasn't doing what I was there to do. So if I did it differently, and I'm not sure if 2020 hindsight obviously adds a lot of context there, but I would probably tend to try to just get out and build those relationships while being facilitated by the Ministry of Health, but definitely looking for opportunities on your own as an embedded researcher, because once I did that, the doors opened. People were more than willing for me to come in and help, to observe and offer my observations to them and how they can improve their work. So once I did that, I found that definitely opened up a lot of opportunity and the ability to see things far and wide and to speak with people quite extensively across the system.
Great, thanks, Sharon. And just to note, we have a comment here from Saskatchewan Health from Terry Blackmore, who is the head of the initiative, the surgical initiative. Just to note, clinical pathways are also playing a role in ensuring that patients receive good information to make informed decisions about surgical or non-surgical treatment options. So that goes back to that earlier question. And thank you, Terry, for that comment. The other question that Stephen had was for you, Dr. Marshallton. You mentioned funding and financing. In the SkSI, how has the province used funding as leverage, if at all, to improve elective wait times?
Well, I think that's a question that Sharon might be better to answer, but the one that I will address will be the one was how could it use it in terms of changing the policy environment. And while that is not a direct part of the Sharon's work, it comes out of Sharon's work, and it allows you to look at the environment and say what could be changed in terms of the environment, in terms of it's not just a matter of financing, but it's the locus of the financing. I mean, currently the arrangement is you have a predominantly fee-for-service system, and that is managed directly by the Ministry of Health. At the same time, the surgical facilities are being managed by the regional health authorities, and all of the other people that are working as part of the surgical process are working for the regional health authorities. So the question is whether you not only can change the payment system, but change the locus of payment in terms of transferring some of that funding from the ministry to the regional health authorities, and in a sense have the regional health authorities decide the better payment system. These are fairly radical options, but they're ones that allow you to really potentially reconfigure the current system and break out of some of the current barriers. Of course, these kinds of changes may create further problems, but it does allow you to rethink the entire arrangement. And I'll turn it over to Sharon to talk about the precise payment mechanisms that were used in the Saskatchewan Surgical Initiative.
Okay, so the Saskatchewan Surgical Initiative used the resource intensity weighting process to provide targeted funding to regional health authorities based on the volumes that they hope to achieve to meet the targets within the time frames. So there was also the fee-for-service was a predominant mechanism used to remunerate physicians, but there was a definite movement and interest on the physicians' part to moving towards more of a alternative payment model. So within the province currently there is quite a mix of fee-for-service and alternative payment models, and it became quite clear that that alternative payment plans were quite effective in enabling some physicians to actually participate in some of the collaborative strategic processes that were under the banner of Surgical Initiative. And I think there's more work that's being done in that area at present.
Great, thank you both. A question here for you, Sharon, from Sarah. During the process, did practitioners ask you for advice and research findings or anything else to support the process, or were you more of an observer? So the extent to which you were a participant versus an observer in the participant-observer process.
Thank you for your question, Sarah. Generally, that varied depending on the situation, obviously. So there was a lot of times that I was just an observer. Like, for instance, I went to Prince Albert Parklands, which is a larger, moderate-sized region that provides considerable surgical services. And so I had the opportunity, because it's not I had to actually go and stay there for 2 weeks, just milling around and talking with people. They then would ask me based on my experience, what it's been like and what I'm observing, and then definitely looking for those, for those learning moments and giving you advice and opportunities for improvement in the area. And then often after meetings, there would be sort of a less formal process where people would ask me about what my experience is like and what I've been learning, and then I'm not sure what they did with that information in a lot of cases, but there was definitely an openness and emphasis on actually incorporating me in what we did. Obviously, the Surgical Initiative, I participated in weekly meetings as part of their branch meetings, so that was always an opportunity for me to offer my feedback, and they were definitely open to hearing that.
Great, thank you. A comment and question from Cheryl. Congratulations and thank you for a helpful presentation. What advice would you give to transferring your methods, specifically this embedded researcher role, to other ministries and organizations?
Stephen, I'll try to manage that, but I'll ask Sharon to make any additional comment.
Okay.
I think it's very important that we extract all of the potential lessons that we've learned from this and put it into an operational manual so that other organizations, ministries, etc., will not have to replicate some of the mistakes that we made early on in the arrangement. But I think the first, and in general, the first job is to ensure that there's a clear definition of what the ministry or other organization is hoping to gain from the arrangement. If they're looking for a simple replacement of consulting services, then this probably isn't the arrangement for them, because this is going to be broader than that kind of advice. Second of all, that if they're looking for a very specific task to be completed, for example, a very narrowly based evaluation exercise, then they would be better off doing that internally or asking, again, an external consultant to come in and to conduct that kind of exercise. So what are you looking for? Are you looking for a deeper and broader understanding of the transformation process and therefore lessons that can be applied in other areas of the organization or ministry? The second aspect of that is to ensure that you have a culture within your organization that will be open enough to have somebody that comes in from outside but can work as a full member of the team, basically with the right to obtain the same information as other members of the ministry or organizational team. Sharon, do you want to add anything to that?
No, probably not. I think you've done a great job, but I think I'd probably, if I was a ministry and had the ability to make those decisions, I would definitely open myself up to that, because I think there's a lot of value that can be gained from these sort of relationships and experiences. So.
Okay, great, thank you. A question here about, did you use a specific model of change management as part of the work?
So again, going back to the initial stages 3 years ago, the Ministry of Health, together with CFHI, had done some preliminary work looking at the elements of change management. So Alan Best and his group at the InSource Research. I'm sorry, I can't
InSource.
InSource, yeah. They provided us. They've since written an article. So there's their ingredients for large system change. So that was given to us preliminary as a model of change management, and to expand on or to basically use it as a tool to validate the tool. So that's where we sort of started out, and then as CFHI has developed their tool, we've definitely used that also as a resource to inform this work.
Thank you. We have a question from Cheryl. What were the dynamics between the political side and the health provider side when it came to implementing changes? Were there times when the two sides were in conflict about what needed to be done to improve surgical wait times? And if so, how was this conflict managed?
Just a point of clarification. Does political mean strictly the Minister of Health and the Cabinet, or does political mean the Ministry of Health in this case?
That's a good question. Maybe what we'll do is, Cheryl, if you could just in the chat box clarify if you're talking about it more of the Minister or more at the more of the Ministry of Health and the Minister of Health and Cabinet. So more at the political side.
Yeah, so I see Cheryl's commented there that it's the more of the political side.
Yeah.
So because I was based within the Ministry of Health, I had minimal to no interaction with the political side personally. Obviously very aware of the fact that that did occur. So I can't really comment on the dynamics between them. To me, they always seem very consistent. The Ministry of Health would take the information from the executive sponsorship group and the guiding coalition, and then within their meetings present that, and the decisions were pretty consistent with generally, for the most part anyway, with the executive sponsorship and guiding coalition recommendations and direction that they were. So it was a very collaborative approach. So to me, there was definitely areas where there might have been a little bit more conflict, but that was definitely managed quite effectively. And obviously the truth is in the pudding, in that the wait times are being reduced, and they seem to be doing a very good job in that regard.
And I would just add that sometimes if there are serious conflicts, that they do become public through the media. Mm-hmm. And during the course of this project, I was certainly watching out for that and keeping tabs on that. And I personally did not find that there was an occasion where this had boiled over into the public arena and that there was a serious conflict between, on the one hand, providers, those working within the system, and on the other, the political arm of government and its desire for change.
Great, thank you. A couple of comments in here, people asking about the references to the change management work that was done by the InSource group. And just to let you know that we can provide those references when we send out the email post webinar. We'll also be providing people later on after the webinar with a copy of the report. And I'll get to that a bit later. So we will provide you with those references, not a problem. There's a question here, Sharon, around what measures at the front line meant the most for the shift to patient-centeredness?
So just at a systems level, as I mentioned, having a policy framework to support patient and family-centered care definitely goes a long way. So collaboratively, again, the Saskatchewan Ministry of Health has been working with representations from all regions on developing a patient and family-centered framework. And there is a clear expectation that each region would, incorporate family and patient-centered care within all of their work. So I think at the front line, the area, the measure that has had the most impact would probably tend to be using the lean tools, which definitely incorporate patients and families in process improvement activities, the quality improvement activities at the front line. So that's where I've seen a lot of people shift in better understanding the role that a patient and family advisor can play in contributing to those sort of process improvements and bringing the patient and family perspective. From a patient's and family advisor's perspective, the people that I did interview definitely felt that their contribution was valued and that they actually were an equal member of many of the quality improvement teams. So I think that's really the measures that have made the most impact at the front line. Also within many of the regions, a lot of the meetings actually involve at both a strategic level and an operational level patient and family advisors, and also they use a lot of patient stories to sort of highlight some of the issues when at the beginnings or ends of meetings. So you can definitely hear the patient's voice throughout a lot of the work.
Okay, great, thank you. Another question for you, Sharon. Did you have particular methods to interrogate micro, meso, and macro levels in your research? And did you develop these or use existing ones?
I like your word interrogate. So after you've been an embedded researcher, you're often thought of as an interrogator, that's for sure. So probably not. I used a lot of interviewing methods across the system. So I sought perspectives from all levels, micro, meso, and macro. So probably not. I just tried to make sure that I considered all levels of the system and heard voices from each level. And then my basic philosophy was that every person's opinion and their viewpoint actually was equally valued. So I'm not sure if I actually answer your question. Sorry.
Okay, thanks, Sharon. This one I will put to either of you. Was the fact that the patients don't pay at the door for the service an issue for the drive to improvement? Some say that public systems don't have the same incentive to improve costs, for example, because the user doesn't see what they pay for. Could either of you comment on that based on this particular experience?
This question, behind this question is a huge debate that has never been resolved between health experts and health researchers as to the impact of direct payment and systems of universal health coverage that cover all direct payments. What we do know is that there appears to be very little difference in terms of systems with co-payments built in and those without in terms of the patient's interest in seeing improvements and their perceptions of some of the difficulties of the system. And co-payments in and of themselves do not really help in terms of being able to assess a system because everything's being costed out, because only a part of the cost is built into a co-payment. So the short answer is we don't know, but the longer answer is, and here I'm maybe betraying my own read of the literature and perhaps biases, but I really don't think it makes, or there's no evidence to support it makes a difference. That said, there needs to be patient response built into the system and real efforts to truly evaluate how patients and users of the system feel about the services they receive, so that it's not simply going to be an endorsement of the organization or the government in question. And so there probably will need to be more independent evaluation. We really don't have as good a read on this as we need to have. And of course we are in the midst of a great debate on this because of the Commonwealth Fund studies, which do look at patient views across countries, and Canada has not been faring well in those studies. That tells me that we should be doing much closer study on this within the country.
Great, thank you, Greg. Well, I think we'll stop it there today in terms of the questions. I'd like to take a moment to thank both Dr. Marshall-Dunn and Sharon again for their presentations, to thank all of you for participating, and just once again to thank the Ministry of Health in Saskatchewan for making this opportunity available to all of us and the learning that we have been able to glean from all of this. Just a reminder that the recording of this session will be made available publicly via our CFHI website in the coming days, and Sharon's final report will be publicly available in both French and English in late November. However, as registered participants for the session, we will be pleased to provide you with an advanced copy of the final English report after the call. So stay tuned to your email for instructions on how to access these materials in the next few days, as well as the references to the other materials, and including a reference to the fact that the Saskatchewan Surgical Initiative is referenced on the CMA's Toolbox website, and we'll provide the reference to that as well as we get back to you post-call. We'd also invite you to check out our other online offerings that are coming up and the full on-call lineup at our website, cfhi-fcas.ca/on-call, and including our next webinar and our next free webinar on November 3rd, where Dr. Chris Hayes, a recent CFHI Harkness Fellow who is based at the IHI, is going to provide an overview of the work he did as part of his Harkness Fellowship, a development of a toolkit which really tries to help organizations measure the time it takes to engage in improvement work and really create the ability for teams to engage in improvement work and address the change fatigue that Sharon had mentioned earlier in her presentation. So I think it'll be actually a really terrific follow-up to some of the issues, Sharon, that you identified in your work. This includes our informational webinar for today. Please watch also for the link to a survey that will open automatically as we close today's webinar, and we would really appreciate your feedback on this session as always. Again, thanks very much for joining us today. We look forward to connecting with all of you again soon.
Thank you. Ladies and gentlemen, this does conclude your conference call for today. We thank you for your participation. You may now disconnect your lines and have a great day.